Hello, this is part 2 of the ICP series. In this section, we're going to talk about nursing management of acute intracranial problems. The first acute intracranial problem we're going to cover is head injury. A head injury is any injury or trauma to the scalp, the skull, or the brain. This encompasses all kinds of injuries. The most serious form of head injury you'll hear is called a TBI, or traumatic brain injury. The most important thing to remember about head injuries is still the concept of ICP and CPP. You'll see that head injuries can cause increased ICP from increases in blood volume, such as with hemorrhage, or increases in tissue volume, such as with swelling, hematomas, or edema. So don't forget all those interventions we just talked about for increased ICP. This is just going to show you how head injuries can cause increased ICP. You'll see that death usually occurs in 3 points of time: immediately after the injury, 2 hours after the injury from progressive worsening of head injury, such as with bleeding or swelling, or internal bleeding, and 3 weeks or more after the injury from multi-system failure, such as with shock or infection. Expert nursing care is crucial in decreasing mortality because we can prevent most of these complications with diligent nursing care. Here I'm going to direct you to the head injury handout that's posted on Canvas. These are important concepts for you to understand, but rather than reading them to you out of the book, you're going to read about them and study them on your own. We're going to focus on the nursing management of these injuries in this lecture. Hematoma formation is the main complication from head injuries. Your textbook goes into great detail regarding the different types of hematomas, so be sure to read about these. This is a brief slide with the key points to each, and we're going to focus on the nursing management of these in this lecture. So please review. Epidural hematoma. This usually occurs with bleeding between the dura and the inner surface of the skull, and it is a medical emergency. Then there's subdural hematoma, where bleeding occurs between the dura mater and the arachnoid layer. This often occurs to older people, and you can have often focal symptoms. Often it's a slow hematoma that develops, but sometimes it can be acute. And then there's the intracerebral hematoma, where bleeding occurs within the brain tissue, often from ruptured vessels from an injury. So now we're going to focus on the assessment. Don't forget everything you've learned regarding nursing assessment for increased ICP, because basically that's what we're concerned with as the secondary injury from head injuries. So even if your patient appears okay following a head injury, now you're going to begin to worry about that secondary injury, which is that cerebral edema can occur. First, we're going to do a complete, quick primary assessment focusing on your ABCs. Is the airway patent? If not, secure an airway. Be cognizant of cervical fractures if your patient just sustained a head injury. You should perform a jaw thrust rather than a head tilt in case there is a cervical spine injury. Check if your patient is breathing. If so, assess the effectiveness of the breathing. Remember, the patient is at high risk for respiratory dysfunction due to possible injury to the breathing centers in the brain. Assess for altered respirations, decreased SpO2, hypo or hyperventilation. What about circulation? Does the patient have any major lacerations that you can see? If so, apply pressure and control the bleeding. Complete your neuro assessment next. Look at the pupils. Ask the patient to follow commands. Do a Glasgow Coma Scale. Is your patient displaying any posturing? Various diagnostic studies are used in the assessment of the head-injured patients, such as a CT. A CT really is the most common because it gives a quick indication of what's going on. Don't forget the cervical spine studies because we can assume the patient has a cervical spine injury until it is ruled out. Now we're going to move on to the nursing process, and next is diagnosis. So here are some potential nursing diagnoses when caring for a patient with a head injury. There are potentially more based on that particular patient and your assessment findings. Notice again here we're worried about tissue perfusion and cerebral edema. Next is planning. We're going to set our goals when caring for the patient with a head injury. Notice that the top one is to maintain cerebral oxygenation and perfusion because we want to save brain tissue. We're also concerned with temperature regulation, pain control, keeping the patient free from infection, maintaining nutrition, and of course maintaining quality of life. These are all going to guide our nursing care. Of course, the best way to reduce death and impairment from head injuries is to prevent them in the first place. Nurses should be advocates of motor vehicle safety, seatbelt use, and helmet use in their communities. Don't forget the older adult population and falls, since this is the second leading cause of head injuries. Nurses should be vigilant in fall risk assessments, fall prevention, and education on what to do if the individual does fall at home. Think of the older population and the medications they're usually on. These can include hypertensive meds, diuretics, and anticoagulants. These can be a deadly combination for the older population. A fall from dizziness or hypotension can result in a head injury and hemorrhage due to anticoagulants. So what should you as a nurse do for these patients? Teach them, educate them, tell them that they are at risk for falls and bleeding in the brain. Tell them if they fall or hit their head to call their doctor right away. Tell them or the family members to monitor them at home and make sure they know what to do if they develop these symptoms. This is our responsibility as nurses. So we immediately want to report, of course, any changes in level of consciousness, no matter how subtle these may be, because it could indicate neurologic deterioration. This is why frequent neurological assessments are so important. We can identify many changes very quickly with a good assessment. Remember, our focus is to prevent and manage any increase in ICP. Our number one priority is to prevent complications from the brain injury. So remember, the brain is going to swell, and we need to prevent cerebral ischemia from that edema. So back to what we've already learned, our first priority is to prevent the complication of increasing ICP. The clinical guidelines for nursing management of adults with severe traumatic brain injury identify 4 recommendations for these patients. Maintain or decrease ICP is number 1. The goal is to keep it less than 20 millimeters of mercury, and we can do this by using the drain of cerebral spinal fluid to control the ICP. Evidence has shown that draining as little as 3 milliliters of cerebral spinal fluid was found to decrease ICP by 10% in a study of 58 patients with severe traumatic brain injury. Another recommendation based on evidence is to maintain normocapnia with these patients. Hyperventilation used to be used to induce vasoconstriction in these patients to reduce ICP, but now studies show that normocapnia is better. The latest guidelines recommend keeping the patient sedated with propofol or morphine, propofol or considering morphine, and it has been shown that propofol resulted in significantly lower ICPs on day 3 after injury. So they're advocating the use of propofol. Don't forget, mannitol has been shown to be very effective in decreasing ICP. Elevating the head of the bed 30 degrees promotes venous return, increases cerebral spinal fluid drainage, and decreases ICP. Also, glucose control. Maintain glucose levels of less than 110. Studies have shown this can result in lower mean ICPs than in patients whose glucose levels exceeded 220. You can do this through tight glucose monitoring and insulin therapy. Again, just like in part 1, we covered the importance of maintaining normal body temperature and hyperthermia's adverse effects on ICP and metabolism, but we also want to prevent shivering, so we're aiming for a normal body temperature. We want to prevent complications of the eye. A loss of corneal reflex predisposes the patient to eye injuries. Be aware of the patient's eyes. They may have lost the corneal reflex, so they won't be able to protect their own eyes from injury, and the nurse may need to administer lubricating eye drops or even tape the eyes shut to prevent abrasions. If the patient has periorbital bruising or swelling, a cold compress is used first, and then a warm compress later, which will help reduce the swelling. You may also need to consult an ophthalmologist if you feel it's needed. Head injury patients are at high risk of infection, especially if you confirm they have CSF leakage. Remember the halo ring test. Don't insert anything into the nose or ear if you suspect a CSF leak. This means no NG tube, no nasal suctioning or airway, such as a nasal trumpet, no dressings or gauze placed inside the nose or the ear for drainage. Antibiotics will be considered if a CSF leak is suspected to prevent meningitis. Don't forget your other nursing interventions you already know. VAP prevention, or ventilator-associated pneumonia prevention, and UTI prevention. Patient and family education is a significant responsibility for the nurse. In the acute care setting, the focus of the education is for the patient and family to understand everything is directed toward preventing an increase in ICP. You should educate them on why you're performing frequent neuroassessments. Educate the family on the importance of a quiet and calm environment, and be a patient advocate regarding this. You can see the ambulatory and home care setting for these patients encompasses a lot of patient and family teaching. You'll need to educate them that the patient may have chronic problems based on this injury. The overall prognosis may take months to account for adequate healing time, and this can be difficult for the patient and family members to accept, as they want to know now how the patient will be. Understand there are different family dynamics that can take place, and the patient may never be able to perform various duties and tasks that they were able to perform beforehand. Some quote-unquote no policies are listed here. These can be given to the patient with a head injury to prevent any other injury in a disabled state. Finally, we come to the evaluation phase of the nursing process. Ask yourself, were your interventions successful? Did you ultimately prevent any increase or worsening of ICP? Did your patient improve? Did you do all of the specific interventions to prevent complications of increased ICP and those that are more specific to head injuries? And if you didn't, or if the patient is not at the point where he's improved, what could you do differently? This is the end of part 2 of ICP.